let me just tell everyone, and I guess repetition is a key to learning. So once more, for those of you who might have heard it, I'm Danny Bobrow. I'm president of AIM Dental Marketing, and you are attending an installment of the Practice Perfection web-based education series. And we are going to be hearing from Bill Rossi about clinical calibration, which demonstrates how to master this ethical approach to practice growth. And as you may have already heard, I've been looking forward to having Bill deliver this presentation for quite some time, because it does offer a way for dentists and their teams to gain greater acceptance of their enhanced protocols. And that's what this is all about. And before I formally introduce Bill, I do want to let you know that the webcasts run for around 90 minutes. They're going to be a little shorter because we're a few minutes into it now, but we'll certainly get to everything. And we'll certainly allow enough time following the presentation to get all your questions answered if we cannot answer them during the webcast, but you can submit those by using the question button on your screen. And you are entitled to receive 2 hours of continuing education credit. We'll send you a survey for that purpose shortly following the presentation. And I have a disclaimer to read because we are a candidate now to offer PACE continuing education credit, which reads as follows. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And now to introduce a man who may need no introduction because he was already introduced.
Because it's probably already been heard, yeah.
Bill Rossi is president of Advanced Practice Management of Edina, Minnesota. And Bill and I have worked together for at least 20 years. He is a 32-year practice management veteran, thought leader, highly respected member of the dental profession. And by the way, I wrote this introduction, not him. His group is actively involved in the ongoing management of over 240 practices. On a monthly basis, they monitor $15 million of dental activity. And
it's actually over 20, Dan.
Is it? Okay.
Yeah, well over. But sorry,
well,
couldn't resist.
Yeah, don't be sorry. Good for you. Even more credibility. Are you working with more than 600 on-site consultations each year?
No, that's about right.
All right, good.
Yeah.
Good. And so because of that, they easily deliver more results to their clients in their region than any other firm or all other firms combined. And it offers a real deep and wide frame of reference so that they can truly assist any practice model, including those committed to oral systemic health. And I think you're going to enjoy it. It's very common sense, it's a powerful approach. It's sort of a continuation of a theme that we adopted over the summer about the power of words to persuade. And Bill takes it a little bit deeper than that by, employing an ethics-based approach that kind of leads the doctor and team to just naturally choose the words, the right words, based on their understanding of their thought process about what is truly in the best interest of the patient. So I think we've covered the essentials there, Bill. So why don't you take
All right, let's hit it. In my field work, I work with dentists of all different kinds, and when I was first training to be a consultant, first getting my experience, it always my uncle was a dentist. That's how I kind of got into this. And it always kind of bugged me to go to practices and say, hey, your crown or bridge should be 30%, or this should be that percent, or that should be that percent. Because I don't think it's appropriate for a businessman or anyone outside of practice to set a percentage which can be sort of arbitrary and doesn't really have to do with the clinical protocols of that practice. Well, I really have to get results from my clients. As you know, Danny, most of the folks that we work with, we work for years. No one's in a contract or anything like that. But I have to not be completely full of it. We have to be able to get results. And I found out real early on that no matter how you try to couch it, trying to make dental hygienists into salespeople or dentists into do that whenever they feel like they're manipulating the patients they love, if they feel like they're selling or pushing the patients they really like, it goes against their grain. And it goes against my grain too. So we found if we went with people's grain, we got better results. So although this starts out theoretical, it's extremely practical. Now, one of the things you know, Danny, is you get calls, I get calls, and someone says, I want to get more new patients. And you go, sure, we'll get you more new patients, but how's your production going? How's your period thing? How's your production recall? All those other things. And the doctor will usually say, didn't you hear me? I'm calling to get more new patients. And I said, right, I can help you get more new patients, But when you're going to get new patients, it's sort of like going to the casino. You got to have money to play. And, you know, I wish you could just double your referrals by some magic water or something, but basically, if you're trying to beef up a practice, you have to make sure you're taking really good care of the patients you already have, and that process gives you the funds to plow back into the practice like seed corn. I grew up on a farm, so you hear a lot of agricultural metaphors like seed corn so you can do better. So having said that, in every practice, there's a gap between what you can do for patients and they choose to have done. And if you put your own values into action, you'll grow by 10,000s per year. I've seen a lot more than that, 10,000s more per month, more like it, through clinical calibration. Patient compliance, or now the Mayo Clinic uses the word confluence, is a real challenge in the healthcare professions. It's something, what is it? You probably heard these statistics, Danny, like 25% of people actually take the medications that as prescribed. 75% of people with chronic long-term health conditions like high blood pressure or diabetes are off their med program or not taking it as prescribed in 6 months, you know. And so if you could give someone a pill that made them comply with their doctor's wishes to take whatever other pills they're supposed to take, you would have actually a better outcome. Okay, so the purpose of a dental office is to deliver patient care. And we measure patient care by production because it's just, you know, the common denominator of all the dental procedures is a dollar value. And so it's a crude, and it can sound mercenary to healthcare people, it's a crude measurement of care delivered. But it works in a way, because if you go to a practice where practice production is increasing, fee increases aside, it quite literally means that patient care is increasing or improving. And if I go to a practice where practice production is going down, it quite literally means they're delivering less care. And
for a given number of patients.
Well, or less patients. And so that gets to my next point. You can deliver more care, increase production by seeing more people, or doing more for the people you see. Well, I measure how many people you see by exams because most dental procedures start with an exam, periodic, limited, or comprehensive. So when I'm trying to judge how much patient flow a practice has, I look at the number of exams. Charles Bowe will look at the number of prophies. In some cases, there's differences, but the idea is I like exams. And so when we're trying to pump up a practice, getting more comprehensive exams, new patients, of course, report, recall, emergency, and so on, that's a whole other subject. That's, you know, centerpiece of what you do at AIMLOT. The other way you grow is by doing more for the people you see, which increases their production per exam. And you can figure that out by looking at gross production and dividing by the total number of exams a month. Now, I'm looking out my window, kitty corner to a Target store up here in Minneapolis, home of Target. And in the Target store, they keep track of how many people go through the cash register lines. That's their transactions. And so, A, they want to get people into the Target through store, advertising, sales, and so on. So that gets people into the store, and then they want to have the right merchandise presented and laid out in such a way that people like what they see and buy what they want. And so they measure how many people go through the cash register lines and how many what they do per sale. At the Mall of America, which is about 10 miles from where I'm standing, at one time, and this is about 10-year-old stuff, they figured that the average sales per person, man, woman, and child that went through the Mall of America visited was about $250. So every retail store kind of knows their average sale. I wonder, and this is not a poll question with this, most doctors don't know their production per exam. Now, every doctor can know that. These reports are in every type of software. This is SoftDent, and I really like SoftDent's reports because they're laid out so well. But that's their production of transactions by code. You can bring that up for any period of time for any provider, all the providers. There's Dentrix. That's a version of that. There's EagleSoft. You can use this one, Service Code Productivity Report, or you can use their procedures by provider report. And of course, for open systems, all the systems have this report. And you look at it and go, what the hell do you do with this thing? I mean, how do you turn this into any kind of benefit to patient care of the practice? But first of all, you get a count of how many exams you did, like I said. That gives you an idea of your patient flow. Now, Danny, guess what's an average number of exams for a doctor a solo doctor, GP, what would be an average, I'm going to put you on the spot, what would be an average number of exams per month?
Per month.
For down the middle practice?
You know, I'm guessing 20 days per month. I don't know, 5 to 15 a day, probably. So 100 to 300.
Yeah, well, it's about 150. 130 to 150 is kind of doctor average. All with exceptions, but so we don't have to endlessly hedge, I'll just say it's that. And so that's doctor average. Now, if you're doing 300 exams a month, that's a lot. If you're doing 50 exams a month, that's not so much. But if you're not watching your exams, you can't tell. If, you know, how do you tell if your recall system's better? The number of periodic exams go up. You can't tell if the recall system's better by going to the front desk and saying, do you think we're working recall? That doesn't prove it. And so likewise, when you're really trying to make improvements here, you want to see your production per exam increase. Now, again, I want to point out, I don't want to have a quota. These are frames of references. If you have more people comply with what you recommend, your production per exam will go up. Because if you're a doctor that says that 100% of your patients comply with 100% of your recommendations, and, then you're either blind or crazy, right?
Right.
So this gives you some frame of references. These targets, like this production per exam, is for a practice like in our metro area where the crowns are about $1,100, the prophy's about 90. Okay, to give your audience a frame of reference. The crown and bridge per exam is about 150, and again, I gave the range there, 100 to 250. Perio per exam is in the 20 to 25 area, but you go to an office and you look at the perio production per exam, and it might be $3, very low, or it might be 60, which is very high. Now, there's a difference between using this kind of measurement and the percentage measurements. So, for example, I've always disliked percentages like your hygienist should do 30% perio, and your hygiene department should be 30% overall production, because those are not independent variables. So, for example, if you're a doctor that does lots of ortho, implants, and other things, your hygiene production as a percentage of total practice production may not be 30%, but that doesn't mean it's bad, okay? And
right.
if a hygienist is doing lots of, huh?
I'm saying, or not profitable. It's just it's the basis of comparison may be skewed.
Yeah, to me those statistics are not helpful. But let's say you're calibrating with your hygienist on perio, and the amount of perio delivered goes up per exam. In other words, you're delivering more perio per patient seen. That means that you're literally delivering more care in the perio department to patients. But you're not going to do that because some consultant says, all right, you're doing $15 per exam, hygienist, and perio, you better do 20. That will get you nowhere because hygienists don't respond to statistics, generally speaking. In fact, you hit your hygienist over the head with statistics, they will dig in. Believe me, we were talking about I did this 32 years. By year 1, I recognized that you cannot go against a hygienist grain real harshly. They are stubborn. And that's because the personality types that go into hygiene are very able to time after time after time deliver a consistent quality. And that same personality trait means you can't push them around that easily. But they'll push themselves if you give them an ethical basis. Everyone with me so far? I wish I knew, but I'm going to assume you are. Okay, let's do a question. Now, let me frame this question before you throw up the poll there, Danny, just for a second. This is just a general discussion question. It's just a mind-type question. There's no hard right or wrong on it. But I want you to actually write down the answer. So, doctors, or whoever's listening, imagine in your mind all the patients that you see in your practice. See the whole patient universe in your mind. Now, what percentage of your patients, in your opinion, do you feel are episodic type patients? That is, patients you only see when something hurts or breaks, and then you fix it up, and then you don't see them again until something hurts or breaks. That we'll use that operating definition of an episodic patient. So this is something I'd be interested in. Okay, you ready?
Yeah, I am. Let's go ahead and launch that. And again, what percentage of your patients are episodic? Take a minute.
Or emergency in nature.
Right. And one question one answer question, either 0 to 10, 11 to 30, 31 to 60, 61 to 80, or greater than 80. Give you a few more seconds to answer. I think we have some honest people here. Just a few more seconds. We've only got 50% having voted. Up, that pushed them up. I guess this does take a little bit of thought. So let's give you a few more seconds. We're going to give you an entire minute, 10 seconds. All right, let's go ahead and close that. And the results are 60% fully acknowledged 0 to 10% as being episodic, and the rest believe that they were 11 to 30%. So
yeah, so 30% are under. That's right. Kind of consistent with what I see when I'm out in the field. I'm going to go to the next slide. Are we ready, Dan? Can I do that?
Yes, sir.
So usually when I do this in the field, I hear like 5 to 50%. That's pretty much on this, isn't it?
Mm-hmm.
And for most practices now, there are practices nowadays, you know, that do, emergency centers, USA and stuff, that do purposely court the episodic patients. But for the typical GP practice, it's going to be in this area. Now I've got a tougher question.
Yep. And
this one will take a little more framing, and this will beg a lot of questions. So patience out there, everybody. But ask yourself this. Imagine that patient universe. Let's go to the other far end of the spectrum. What percentage of your patients are, in terms of gum tissue, aesthetics, occlusion, their oral systemic health, as you might say, Danny, they are at optimal. They are voila. Now here, this is a harder question to frame, which is the point of this whole presentation. But what percentage of your patients, in your opinion, you feel are just, they have arrived dentally, they are at optimal? Let's pull that.
And the answers, the options are the same. For some reason it closed. Let me open it, see if I can open it again. All right. Unfortunately, that poll got closed prematurely.
Okay, I'm just going to keep going then. Okay, you're going to have to trust me on the audience. I've done this a lot of times where I've asked people, and I'll get a much greater range of response. I would have bet you serious money, Danny, that when you did this poll, you would have seen much less of a unified type thing. It's all over the board. You know why it's all over the board is because the definition of optimal is quite a challenge. It's kind of like trying to define beauty. Let's say that you tried to quantify beauty. You know, the skin a certain color, the hair a certain shade, the eyes. You know, there's a lot of different versions of beauty, and there's lots of different tastes in beauty, but you kind of know it when you see it. I think a good operating definition of optimal is not perfect. It's the kind of condition you would have in your own mouth if you had that patient's age and genetic conditions, what you would go for to have optimal dental health. And like I say, this is usually a much greater range. But what is optimal is quite a question. For the older guys in the audience and women, they'll remember the book called Zen and the Art of Motorcycle Maintenance. And that book centered around what is quality, what is the definition of quality. And it's easier to define ugly than it is beautiful. So what I didn't tell you about is the middle range. So usually when I map this out, when you look at a practice, you know, 5 to 15% are at episodic. When I ask everyone, we end up with maybe 30%, 20% at optimal. And that leaves that middle group, which is the balance of the practice, which I didn't tell you about, which is maintenance. And most practices, GPs I work with, they, through this simple sort of mind-guessing deal, will say that the maintenance is the largest group in the practice. These patients aren't necessarily just coming in when they're in pain, bleeding, swelling, but they don't have the best you have to offer either. They might have a nagging perio condition, or they aesthetically not there, or some occlusion, or they just, some old dentistry and or other things that are just pending. And they may be okay, but they're sort of in a state of deterioration as they age. Can you relate to that, Danny?
Yeah, would you agree that maintenance is sort of a catch-all for, well, they're not episodic and they're not optimal, so we'll throw
Yeah,
it in
it's the in-between stage, and for most practices, it's kind of the patients are sort of in a holding pattern. And the way I put it to my clinicians or the doctors I work with is, if your patients are kind of in a holding pattern, the practice will kind of be in a holding pattern. But on the other hand, I want people to get down on themselves, because in most practices, again, if you say 95% of your patients are at optimal and you're clear on what optimal is, get off the line, because you already got everything down. But I rarely see that, and because it's an endless challenge. So I'm going to go to the next slide on this. So I call this the EMO scale: episodic, maintenance, and optimal. And I'm going to give a little, now again, I got to ask for patience from the listeners here, because I'm talking general, but I promise you, before this is over, you'll have things that will do more for your bottom line than almost anything you can do, besides dealing with PPOs, which is a whole other thing. But here's the thing. Look at this historically. If you went back 100 years ago in Minneapolis, or let's say you used Chicago, your hometown, Danny. If you went back 100 years ago, what percentage of the dentistry being done would have been episodic?
100?
Yeah, about 100. Go back from about 100 years ago to about 10,000 years ago. That's, that's what dentistry has been. You have an episode, a toothache, something like that, and you go to see the dentist, the barber, or whatever was like a dentist, and they would pull the tooth or do something to end that episode. And that was the case too, and still, of course, is the case in a lot of the developing world. Well, in our country, I'm generalizing, but I think you'll get my point. In our country, mostly right after World War II, when there was a GI Bill, lots of dentists, prosperity is increasing, dentists started changing their tunes. They said, don't wait till you have an episode to come to see us. Come on in and get your checkup, and we're going to tell you what you need to have done, and we're going to fix your problems. And then if we fix your problems, then we're going to have you come back regularly so we can maintain your oral health, right? Mm-hmm. And so in most practices, that's why most of the patients are at maintenance. They're not at episodic. They've gone to the maintenance level. And that was really the case in the heyday of dentistry in the 60s, 70s, and 80s, where everyone was getting dental insurance. There was prosperity, and more people got to maintenance, plus dental IQs are up and so on. Well, when the step between episodic and maintenance is a matter of telling people what their problems are and fixing them, when you move from maintenance to optimal, it changes all the rules. Why? Why, Danny, is it different moving people from maintenance to optimal than episodic to maintenance?
It represents an entirely different shift and in their relationship with health and their ideas about prevention and really taking, being their own advocate for their own health care. It's a much more substantial shift in mindset than going from episodic to maintenance.
Right. I mean, if you're in pain, bleeding, and swelling, you have to do something about it. When optimal, the further you move up this ladder, it's more and more a matter of choice. The epitome of a discretionary procedure would be whitening, let's say. And so as you move people up that ladder, the rules of the office change too, because it's no longer a matter of telling people what they need, or even necessarily fixing problems per se. It's a matter of showing them what their choices are, and giving the best advice you can, and what the possibilities are, not just the problems. And it's a matter
I think it also means taking, kind of running the race at their pace. And I see this process very similar to, getting the patient. You were talking earlier about, getting the phone to ring. And I will just say that, fortunately, I don't hear what I used to hear a lot, which is, I think, a variation of what you were saying, is you tell people, somebody calls and says, I want to get new patients, and you try to explain that it's a process and that you get the phone to ring and then you have to convert the call, and they say, no, just get the phone to ring and I'll take it from there. And I think more and more doctors and their teams are beginning to realize that this is a chain, which is a series of links, and they've got to take them one step at a time. Moving people to optimal will be easier or more difficult depending on the patient. And you've got to run the race at their pace.
Yeah, and recognize that if you're in an environment where there isn't a lot of frank dental need, decay, like in the pre-fluoridation times and stuff, that it's a matter of choice, and if the patients have to choose it, then all the roles of the staff change. So instead of compliance, you're looking at confluence, like I said. Instead of having a factory where the emphasis is on efficiency and busyness, you're looking more like a faculty, to use alliteration here, more a matter of making everyone being effective and giving good advice, so that the patients choose the best choices for them of the possibilities and enroll in the health process. Okay, that sounds kind of gobbledygooky, but here's what happens. This shows your intent with your patients shows in your semantics. So let's go to the next thing. If you hear yourself saying these things, that means that consciously or subconsciously your goal is to maintain people's health, which is okay, but that's not the same as bringing them to optimal. So if you hear yourself saying, we'll watch this, someday you'll need, this is something for you to think about. If you wouldn't be thinking about it in your own mouth, you'd just be choosing to do it. You may want to consider, this will hold, we can get by with, this will do. Think this over and let me know what you like to do. Let's see what insurance might cover. Here's a cure for that one I think I got from Howard Ferrand. It's your mouth, you don't care, I went to dental school, I don't know, let's send it to a bureaucrat and go from there. And so that's the way he put it. You should. Patients, that's a parental sort of thing, of the episodic deal. It never works to tell people you should. And I violate that all the time as an advisor. I go, you should do this. You should do, you should move more of your patients to optimal. Well, you say should to adults, it just doesn't work. Everyone would floss if you could just say you should floss, right? Remember that? I think you need, this is a future count. All those semantics represent unclear thinking. What they are is the doctor really saying, I like the patient, I don't want to shock them, I don't want to come on as a hard salesperson, so I'm going to take my advice and cover it with fuzz so they don't really feel the edge of it, and I can go about my business and wonder why I'm not busy enough.
Well, and I think really, too, to be just honest and direct, we all try to avoid rejection because we hate it. And nobody likes to feel rejected. And if you say things that you realize do not require a decision or a decision, then everybody leaves and you're not made to be the bad guy, because people tend to shoot the messenger. They'd rather be told a lot of these items, which is,
Yeah, and again, so you do have to deliver the stuff, but you can't. I remember I was out in New Ulm, Minnesota, and obviously a lot of German immigrants there. And I'd just been to Germany. I went to New Ulm, and I said, this place looks more German than Germany. And they said, yeah, we didn't get bombed, So maybe that's a bad taste joke, but that's what they said. But anyway, so I'm going there for my first meeting there. And every hygienist there, including one hygienist who was the doctor's wife, they're all, veterans. These are people that have been there forever. And I said, you guys really love your patients, don't you? Because their arms are all folded across their chest. They're going, some guy comes from the Twin Cities isn't going to tell us what to do. And I could, of course, sense that. And I said, you all like your patients, don't you? And they go, yeah, because their patients are their relatives, ex-relatives, people they sit on the soccer bench with or at the school board with, their husbands work with, their wives work with. I mean, their patients, they all had dual relationships with them. And they are not going to do anything that will hurt their friends. They like their patients. And I said, the problem is you like your patients, and when you like your patients, you don't want to tell them bad news because you think they may not like you. Or they've been shooting the messenger for thousands of years, like you said, Danny. So, if you like someone, you don't want to tell them bad news because you're empathetic towards them and you know it bums them out. And so what you do is take your thinking and muddle it up. And it's patronizing, really, but you have to figure out a way, and this is what this is all about, where A, you clarify what you really feel is in the patient's best interest based on your skill, knowledge, the research, and B, how to present it in such a way that there's no manipulation or contest, that the relationship with your patients, whatever they choose to do on the EMO scale, is kept solid, so that the relationship with the patient maintains, but the patients get good advice in addition to good clinical treatment. So, expectations. Remember, your expectations will be a direct reflection of your own expectations. What is your goal? Maintain their health, or is it do the best to get to optimal? Well, of course, it's to get to optimal. Okay, then your semantics will show it. So these semantics are better because they are not threatening. They're just clear ways of giving advice. The best long-term treatment is, for best results we found, this is what I do in my own mouth. I know you all do that. This is what you should do. There's my should. I got to get that off that slide. This is what you should do if you can do it. We feel the best fit. We've had great results with. Patients have been most happy when the research shows, this one I really like, the best advice I can give you is, we've had great results from, okay, it's really, so you're using terms that relate to optimal, best, what the research shows, and there's other ones that I really like. When patients have chosen to do this, they've been glad they have, that sort of thing. Now, for a lot of doctors, they get caught in what's called the predictability trap. And the predictability trap, I picked this up somewhere. I can't remember who I got this from, but I'll steal from everyone because I've been listening to other people like Kathy Jamison and many others for years. And so I try to learn from everyone. Anyway, the predictability trap is this. This is where you hear a doctor, hygienists nod their head all this time when I bring this up. But they say, well, we could, we should probably maybe someday crown that tooth. I mean, it could break. That filling could break tomorrow, or it could break 10 years from now, or a week from now, or 8 years from now. I don't know. And the hygienist is sitting there rolling their eyes going, oh, my God. Well, the patient knows this. If it crowns $1,000, that's $1,000 now, and you're saying maybe it could be tomorrow or 10 years, at which point the doctors will usually chirp in and go, well, it could be tomorrow or 10 years. I go, I know, but I presume in your brain you already made that calculation before you recommend it to the patient, or you shouldn't. So somewhere in your brain you looked at their situation and thought, if this is my mouth, I crown this now. Or the best advice I can give the patient is crown this now. But when you present it to the patient, you have to shift the premise because you cannot predict their biology. You cannot predict when their crown's going to, that tooth's going to break. And if you try to,
behavior or their luck. Yeah.
Yeah, they come back a year, hey, it didn't break yet, because you can't predict that. But here's what you can say. It's been our experience that other patients with conditions like these have had their teeth break. So that's why I'm recommending we do this now. So what you're doing is talking about your own experience and knowledge. The research shows that it's best if we do this. That's why I'm recommending we do this. But you're not trying to predict the day their tooth falls out or breaks or cracks or whatever. And that shifts you from the predictability premise to just being a good advisor. But there's no pressure to the patient, which I really want to emphasize. So these semantics, these are two most underused words in dentistry. Not I think you'll need, or someday you'll need, or you should. It's just I recommend. Do I have to, Doc? You don't have to do anything. This is your mouth, and we respect whatever decision you make. I recommend this, and here's why, but you just tell us what you want to do, and we'll do it. Now, there's a little Greg Stanley and Paul Homley in there, too, for the people out there that follow all those things. But I recommend says it. But in order to recommend, you have to be clear in your own thinking. And that's, again, where we're coming to. But the semantics, the way you talk. So I've gone in offices, and I said, we're going to start a staff party fund. And so every time the doctor says watch, when in his own mouth he wouldn't watch it because you've been through the calibration thing. Or someday you might need where you go, well, what do you recommend now? The hygienist or assistant can find him $1, and it goes into the staff party fund. Usually most doctors learn in about $12. I mean, it's amazing. But you have to have that kind of fun feedback so the staff rats you out and stops you to break that habit. And it kills me. Doctors have to fish in their pocket for $1, and they go, and you go, well, you've had hundreds of thousands of dollars of dentistry walk out your door. and you're bugged about $1, I usually say I'll match every dollar you have to spend, doctor, but usually they spend about 12 before they get. Okay, this is what's really critical here, better outcomes for patients. In dentistry, the limiting factor is not really the science or technology, it's the patient's choices. It's the behavioral aspects. Again, let me state the obvious, but this will make these exercises that we're getting to worthwhile, which is everything I'm leading up to. I have a next-door neighbor, or he's 2 houses down, that's a neurologist. He's a research neurologist for the University of Minnesota, or was. And anyway, he's from Japan, and real smart guy, and kind of speaks in broken English. And I was hanging out with him one day, and we're kind of joking around, and I said to him, you know, Akime, I said, it's been my experience with you neurologist types that you go through all the school and all this research and stuff, and all you can really do is name that disease. You know, I had Guillain-Barré syndrome, Danny, when I was 26. You know, they can't do much. They give you some pills, sometimes some prednisone or some. You know, MS, they try to mitigate factors. You have Munchausen's. Can you do anything? Not much, but that's what you have. So I'm going down and he goes, you know, that's pretty much true. So I kind of bummed him out. But it is kind of true. In a lot of fields of medicine, all they can do is manage failure or name what the, you know, you have ALS. Can you do much about it? No, but that's what you got. Okay? In dentistry, almost any patient that walks into your place can have optimal if they choose to have it. The limiting factor isn't science, it isn't technology, it's the patient's choices. And so if you want to get better outcomes for patients, and you really want to get better outcomes for patients, you have to take the behavioral aspects of dentistry really important. Everyone knows that, but I don't see a lot of people really working on it. And so here's the deal. Patients' behavior and choices won't change unless you change your behavior and choices. So, for example, if you don't play the staff party fun with a watch bucket or don't have a meeting with your staff on clinical calibration, which we're coming to, if you don't see your staff behavior or choices change, and it doesn't have to be a lot, good luck on making things happen. So I see sometimes where doctors will come back from a seminar and go, okay, gang, we're going to produce $10,000 a day or X thousand dollars a month, and they put everything up on a big whiteboard. I remember Quest used to do that for us old-timers. And you put all these statistics out, statistical goals, and then you crack the whip, but there would be no method really to doing it. Let's just do it. It's like you know, a coach is saying, we're going to win. Let's put some points on the board, but there's no practice or plays. And so that's why I'm going to get to how you can, without spending any money, change your behavior and choices and therefore get better outcomes. If you get better outcomes, you'll do more per exam and you'll produce more and have more money. So these are clinical calibration exercises. And here's the key thing. I'm going to give you a bunch of these and explain them because this is the heart of the presentation now. You have to actually do them. You can't think maybe doing them. You can't do them in your own head. You have to actually do them. Lots of times they say, do this, and they go, oh, did you? You have to actually do it. If you're not changing your behavior and going through these very simple exercises, good luck getting the patients to say yes now to this, that, or the other thing that you're trying to advise them to do. First one is kind of a crude one, but it works. Crown counting. I got this from Tom Smead, who was my mentor out of Kansas City, and God, I've used this hundreds of times, and it works. I guarantee you, if you're a GP and just do this exercise, you will have a bigger month than if you don't. I guarantee it. Just do it. Here's what it is. You and the hygienist play a game where you look into each patient's mouth for 2 weeks, and you pretend that mouth was in your head, and you count how many crowns will be getting done if that mouth was your head, or you know, or you were in the patient's skull, okay, and you write that number down on a day sheet. You used to have those day sheets. If you probably don't have those anymore, but you take one side where you note the number down, and the hygienist is playing the same exact game. Both of you are noting what they would do in your own mouth that the patient isn't doing, whether it was presented or not, regardless of the patient's dental IQ, background, or anything, just based on what you see there. Now, the hygienist, I don't want her to purposely try to match up. I want her to use her own value system, and you're using yours. And then at the end of a 2-week period, you tally it up and say, how many potential crowns did you see in 2 weeks? I saw 12. How many did you see? 22. Whoa, we're different. And then you talk through that. Where did you see 22? Would you really do that? You know, and so what happens is it begins a discussion. But there's an ulterior motive here. What you're doing is yanking your hygienist's eyes above the gum line. So they're not just diving into perio land or flossing land. They're recognizing that you actually value their opinion. Now, they're not going to make definitive diagnosis. We want the patients to be involved in co-diagnosis. They don't have a dental degree either. So we want the hygienist to discuss the treatment they're seeing. And so the crown counting, basically, what it does is break through the complacency. Let me give you the example of this. Years ago, as a rookie, I'd be going to office and say, your percentage of crown bridge seems low, doctor. And they'd say, well, blow it out your shorts, buddy, because I'm doing all the crowns I should. And I go, okay, end of subject. Or I'd say to the hygienist, we should do more, and they felt like, oh, yeah, you want us to sell more of our neighbors and friends dentistry so you can be a hotshot consultant. It didn't work. It didn't work well, I didn't think. So what I did is say this, do this crown counting stuff after Tom taught me that. Let's see what you see, because otherwise offices are usually really defensive. They go, we already do all that. We already do it. And I go, okay, checkmate. I guess there's nothing we can do. Okay, so I say just do the crown counting for a couple weeks. And time after time after time, when I come back, I'll say, okay, did you do the exercise? Yeah. How many potentials did you see? X. How many potentials did you see? Y. They're pretty close. Okay, good. Right away, the hygienist has more confidence in recommending what she's seeing. So you, Debbie, the hygienist, when you see that and suggest to the patient the doctor may recommend or may advise you to, you know that most of the time you and the doctor are going to be on the same page, right? Yeah. Okay, what else have we discovered here? Well, that's not all done yet, right? No, there's plenty to do. So we don't have to make up treatment or over-treat or any of that stuff if we can only get patients to make the right choices voluntarily without manipulation. If we advise them well, they'll make better choices. We have plenty to do. Yes, we do. Usually in most practices, the different 1 or 2 more crowns accepted per week of the stuff you're thinking in your head, sort of, if you clarify your language, will get done, and you go, wow, all of a sudden we are doing thousands more a month. But you can go to bed and sleep at night because you're not going against your own grain. So there's my sermon on that. Now you can count anything. You could count fluoride treatments. How many patients would have fluorides ideally? Or implants. How many of our patients could have had implants? Or dietary supplement, whatever you're into, you can count. And just say, let's look. For example, let's say a doctor says to me, I'm thinking of getting a new panel machine. What do you think? I go, I don't know. What are your criteria for panel? I don't know. Well, let's think it over. And then I'll say, do panel counting for 3 weeks. How many patients that you saw in the next 3 weeks after 3 weeks? So how many did you see that you would think a panel would actually be a benefit to that patient? You know, if it's 2, probably not. You go, oh. And then at the end of 3 weeks, you go, we had to think about our criteria. Because I detest things that say, well, we're going to take panels every 3 years when the insurance pays for it. I mean, you're hitching your wagon to the devil that way. Don't do it. It doesn't matter what the insurance covers. What do you believe in? Fluoride is a classic example. Most offices, well, lots of offices out there, well, it's about half and half actually. Half the offices out there do kids' fluorides every time the kids come in for prophies, and half do them once a year. When I see that, I say to the doctor, I notice that you do about half as many fluorides as you do prophies. Is that because you're doing fluorides once a year? Yeah. And I say, is that because of the science or is it because of insurance? And they all say, well, it's because of insurance. It only covers it once a year. And I go, you know that insurance originally didn't even cover fluorides at all? The doctors started doing them because they found it's patient's interest. Now, when I go to the practices where they do it twice a year, I say, do you have problems with parents when you say one's on the insurance company and one's on you? No. What are you talking about? It's like, for the people that are doing it, I mean, there are some in the practices that do fluorides twice a year for kids. There are some parents that decline. But for the most part of the office believes in it, they do it. Now, flip over to adult fluorides. You know, look at how many fluorides you do per 100 adult prophies. Most of you out there, well, in this audience may be different, but in the typical GP audience, under 10 fluorides, you know, fluoride varnishes per 100 prophies. That's real common. And I'll go through the same thing. Is that because of the science or because of this? Because if you can't calibrate on fluorides, well, there was an article in the 2008 ADA, the Canberra thing, where they go through all the criteria. And if you look at that criteria, sensitivity, exposed, and if you look at that and you think that 5% of your adults is a good ratio, probably not. But this, again, is not a quota. It just begs the question. Are we presenting what we believe in? Now, if you present what you believe in, like if you say, I don't know if the parents will accept twice a year doing kids' fluorides, but it's what we recommend. And 100% of your patients just say, no, we're going to do it once a year when insurance pays. You can still sleep at night because it is their choice. But it's been our experience that if you're clear on why you're doing it, you've done the research, the patients can feel it. And you don't have to be manipulative. You just say, we really feel this is best, and they pick that up. And it's not a problem. But even if only 1 out of 100 patients complied, you have to give them your best advice. You have to do it. But you don't do it in such a way that makes them feel cornered. So you can count anything. The EMO scale audit, I'll go past that quickly. On the EMO scale, what you're doing is you just pull 10 charts and divide yourself up into 2 groups, or pull 20 charts. And divide the office into 2 groups. You know, if it's a normal size office, 4 on one side, 4 on the other. And then you look through your 10 or 20 charts, and you note on a scale of 1 to 10 where you think each patient is on the EMO scale. And you kind of give each patient a name and a grade, and then an average grade for your, and then you switch charts with the other group. So everyone by the end of the exercise has looked at 20 charts and graded the patients on the EMO scale. And then the 2 teams compare their scores. What did you come up for, Mrs. Murphy? Our team said 5. What's your team say? 8. Wow, why did you say a 5? Well, she had some bleeding and infection there for some time. I think that needs to get fixed. Or just aesthetics, she just doesn't look good. There's a discolored incisor or something. So my point is, you go through that, it just opens up the discussion. Now, if you had the same meeting with your staff and sat down and said, how can we push more crown and bridge around here, you're fighting them. If you go, what do you think, and involve them in the discussion, you really get what they think, and it can be really helpful. So that gets on to my next thing, Clinical Policy Summit. And we're going to have a question here, but don't go to it quite yet, Danny, okay?
Okay.
So on the Clinical Policy Summit, here's the deal. You and I have talked about this, Danny, but almost every practice I know of in the last 10 years has had a meeting on HIPAA, OSHA, when they're going to have their summer picnic, cancellations and failures, which, by the way, will always be with you as long as you schedule humans. All these typical things, maybe even your practice goals. Almost every practice has had a meeting maybe in the last 10 years on one of those things. But when I ask, what percentage of your practice has had a meeting on protocols, I get a different number. But I want to explain what that meeting is before we do the poll. So the idea of a clinical protocol summit is you allow for about 2 hours, clinical policy or clinical protocol summit. And what you do is you just go through all your procedures from adult fluorides to x-rays. And here's the process I recommend. This also is something else from Tom Smead that I found useful. What you do is start with a subject. Let's say crowns. I know you guys do other procedures. I'm just using these because they're kind of central procedures and easy to talk about. So you say, everybody, we're going to do a 3-minute brainstorming thing here. So I want everyone in here to write down for the next 3 minutes, all the hygienists, front desk people, doctors, what criteria that if you see, or conditions that if you see in a patient's mouth, you feel the best solution for that patient, the solution you would want for yourself or a close family member would be a crown. And write down every condition that you think would warrant that. And then you give them 3 minutes to just think and write, because once people start talking, they stop thinking. Then at the end of 3 minutes, you poll each one. You say, deal 1 from your list, Judy, 1 from your list, Debbie, 1 from your list, Eddie. And you do this until you get everyone's criteria up there, and then you test it. Well, I think if there's a big filling. Really, how big is big? Cover over half the isthmus? Yeah, it has to cover over half the isthmus. And does it have to be a filling that's deteriorating or just big? No, there has to be some deterioration. How much deterioration? So you start testing things like that. A root canal tooth. Really? What if it's not really an occlusion? I mean, no, I think we should do it. No, I don't think we should. Okay, so what you're doing is purposely, just like if you're trying to pass a PhD or something, in a respectful way, you question each other's criteria. Now, why do you think you do that? Because if you test the criteria with yourself and your staff and your thinking, you're basically doing a dress rehearsal for talking to the patients. Because when a patient says, why do you think I should do that crown now? Instead of saying, because the consultant says we have to get to 33%, ma'am, you're saying, because in situations like yours, we looked at other patients like this, and this has been the best choice. And we had a discussion about this the other day. This is the kind of condition where it really does you no good for us to pretend it's not a problem. Okay? And so what happens is, because your staff speak in the same language, literally, typically as most of their patients do, if you really have involved them in thinking about things, you don't need a lot of sales coaching. They automatically get it if they've been enabled. So let's ask the question. What percentage of your audience, Danny, have had a clinical policy summit in the last 12 months, a meeting solely devoted to your protocols, clinical protocols?
Great question. And I think a particularly appropriate one for our audience, who are really committed to an enhanced level of care, and so many procedures that are really new or leading edge, and therefore I think really require a close look to be able to ethically recommend it to people. You know, is this something that you would want for yourself? And if so, why?
Yeah, particularly as you do the more edgy stuff, new stuff, the patients are going to test your thinking. You better have a dress rehearsal. And again, not a sales dress rehearsal, and an actual thing like you would do, like you were in front of a jury of your peers. How would you justify what you recommend?
Like defending your dissertation. I like that.
Yeah, just like that.
All right. I think, are we looking at what percentage of a response have we gotten? Virginia, we closing the poll?
67% have voted.
Okay, let's just give it a little bit more time. I think the poll automatically closes after a minute, by the way.
All right, should I go ahead and close that?
Yeah, go right ahead. All right, the results are that 21% said yes, they have had a clinical policy summit with their team within the past year.
You know, and that is your group here, because I noticed in that previous presentation, the webinar, I forget by, what was her name?
Tony Adams or Shirley Gutkowski was our last.
Yeah, I mean, and they said like there was a lot more people that answered a similar question than I would normally get from an audience. So
I told you, Bill. I told you.
Yeah, that's good. And you know, of course, if you're keeping up with the science, you need to do this every year, because the next year, okay, when do we recommend that we use Emacs on a crown? When do we recommend we do this? You know, there's a big transition over from the 2752s to the 2740s, and when is it appropriate, when isn't? When is it appropriate to do, not try to save a tooth with a root canal, instead do an implant? When's it better do an implant than a bridge? And if you don't talk this through your staff, unless they're truly psychic, they're not going to really have it.
And I think what's really important, what I like about your approach is that you just put your procedure or your protocols or your philosophy here, inserted here, because this is just an exercise of how to frame the discussion and how to come up with what you feel and get a consensus on what you feel ought to be your protocol for your practice.
That's right. And here's the deal. You want to write it up. So let's say you do fluorides or x-rays or whatever it is, and then what you do is write up a concise written statement that's so simple and straightforward, even a temporary hygienist could read it, or a temporary doctor could look at it and go, okay, I know what you want for your patients. When I see these conditions, this is the recommendation. So you don't have to have them guess. And this really gets me, because I was doing it again today, because I had an office that added 2 associates, and it was quite a successful office, great place to be. And it's shocking to me, not in this office, but it kills me when doctors add an associate or 2 or 3, and they never talk about this stuff. They just assume that the other doctor will infer it. And so lots of times doctors are almost uncomfortable talking about their procedures like it's inappropriately intimate. And it's the best thing a senior doctor can do with a junior doctor is talk about, well, what do you think of this case? What would you do? And so if you develop these concise written statements, your manual, I hate thick manuals. I mean, your protocol manual should maybe be 4 pages thick, if that. And if you do that and think clearly, it will be concise. You know, and that's the case. Hygiene protocol is the same idea, and I'll show you something later here as we zip through the remainder of this. Hygiene protocol is just discussing hygiene things because that's, you know, so many hygiene procedures are process-oriented. And when you get to your systemic protocols, that's the case. And so defining what's perio and when it's referred and when you do a 4342 or 4341, that's a whole set of challenges in itself. And hygienists particularly need to be on the same page. You'll go into offices where they have 4 hygienists and they haven't even calibrated their probing. You know, I'll go, are you confident, Betty Lou, that Debbie, when she gets a reading of 4, you would get a reading of 4, within at least a millimeter of 4. And lots of times they get these kind of, we're not even using the same probe, much less the same technique. And so I go, hey, you got to have your lead hygienist take a few test patients and you probe and then you all calibrate to her so clinically you have the same findings. Because it could be a problem if one time the patient comes and they have perio and the next time they come and they don't. You know, oh yeah, that could be uncomfortable. It'd be a problem if, Debbie, you're recommending fluorides, but the next time they come, Susan doesn't. And both times the doctor's clueless and isn't even on the same page as you. How the heck? And if you can't get things going with fluorides that are cheap, not technique intensive or hard, and you can't get that going, good luck with you know, implants. So hygiene protocol coming up.
This might be a good place to start with the hygiene summit.
Yeah, you know, the diagnostic protocols. How many probes do we do? Who do we do probes on? That's a good one. I like fluorides because they're so simple. Like I say, if you can't get your act together with fluorides, good luck with more complex things. Doctors doing exams together. Again, I grew up in Rochester Mayo Clinic. You're hardly ever alone in a room with a doctor. There's always residents there, no matter how embarrassing the position or the topic. And they do this because they have the staff surgeon follow, you know, the residents follow the staff surgeon around or the experts. They listen in, and hopefully by the 300th patient or so, you've got the residents thinking like the staff surgeon. And with a doctor, I'll see doctors that have associates that never did an over-the-shoulder exam with them, which is insane. I mean, it's just absolutely insane if you think of it. So the doctor just simply says, I'm Dr. Rossi, I'm your examining. Dr. Day and Dr. Smith is also going to do the exam. It's the way we calibrate things. It's the way we doctors discuss the treatment. Most patients will get it. They have no problem with it, and they go fine. Now, you don't want 2 doctors examining and recommending in the same room. So one's a silent examiner, and then at lunch they go out and say, okay, what was your treatment plan? What was mine? Where were they different? What do you think? And you test each other's thinking. What would you present now to the patient? What would you wait on? And if you do that, you're going to have an associate that's much more successful because they're diagnosing like you are, and you're going to feel much better, and the patients get a consistent message. Statistical ratios, I've already hinted at these. Look at your Crown and Bridge, for example, your hygienist ratios like fluorides per kitty prophies and stuff like that. Ask the question, does our rate of presenting and delivery of X service to solve Y condition match our experience in observing Y condition? Okay, like if 50% of your patients have sensitivity, but you're not presenting 50% of them fluoride, let's say, is one of the solutions to that, that means you're not consistent. It doesn't notice here that I did not talk about if they accepted it. I talked that you presented because I don't want pressure on you, and we'll talk about that later maybe. I just want you to make sure your presentation is done consistently, just like you sterilize your instruments. Track shrugged off treatment.
Precondition. I mean, if you don't present, you're certainly not going to get acceptance.
Right, but a lot of times people don't present because they don't have time, or they haven't thought it through, or they don't really feel obligated to, or they think the patient's not going to say yes anyway. And if you present in a way that doesn't pressure the patient, you can give the patient the benefit of your knowledge without having them feel anything icky or you either. Tracking
Right,
shrub
well,
valve
and
treatment.
just to underscore the point, you know, if a doctor wants to be proud of the fact that he gets 100% treatment acceptance, but he only presents to people that he knows are going to be a proverbial slam dunk, you're measuring the wrong statistic.
Right, that's right. I've never, I think we're going to talk about that later, but can I just go there now, Dan, because
You may.
I just think that's so germane, because that's another statistic I don't like. What's your closing percentage or treatment acceptance percentage? A, it's arbitrary because what are you presenting in the first place, which is the point you just made. I mean, if you're just presenting teeth that are cracked and broken already, that doesn't really count unless that matches your criteria. So that begs the question, what are you presenting in the first place? But more importantly is this. I don't want the treatment coordinators in the office I work with or the hygienist or the doctors to feel pressure about their closing percentage. I don't want that. I want them to have great case acceptance. But if you make the hygienist feel like she has to, or the treatment coordinator has to have an 80% closing percentage, that puts pressure on her, and then she'll put pressure on your patients, which can destroy or distort the relationship you have with your patient. So I don't like anything that even smells like a closing percentage. We want great acceptance, but we don't want any sense of pressure on anyone's part, because it is not conducive to a healthy environment.
Excellent point.
Okay, so tracking shrub valve treatment, that's a low-tech way of doing it. Everyone has systems that track treatment, and you go to them, can I get my pending treatment report? Good luck printing that out. I mean, talk about, I see one of those reports, you get this pile of paper. It's, it's like looking into an attic that's been an attic for 100 years. I mean, what the heck is in there, or basement? It's just full of crap and haywire and everything else. It's just too much. And so I sometimes, for immediacy, say you can't have a great substitute. I mean, you can't beat really just having a notebook. And for 2 weeks, you actually really do this. You have the front desk track how many patients shrug off treatment. Every office has this thing where you tell the patients to do things, doctors or the hygienists do, or the assistant, and the patient gives you a face, yeah, sure, okay. And then you send them up front, and they say to the front desk person, you know what, I have to call you after I get back from vacation, or I left my calendar at work, or I got to check with a wife, or I got to check with a husband, or let me do something, I got to call you. Can you run a predetermination and get back to me? And everyone has that happen. And if you just simply list that for 2 weeks, you can see how many times patients go to the front desk, take your diagnosis, and basically put it on a shelf to go out into the world. And it gives the treatment staff feedback, because a lot of times doctors aren't really aware of how much of this stuff bounces at the front desk, because somewhere between the treatment room and the front desk, the patient went out of confluence. So anyway, I think you can't beat that, but you actually have to do it. Oh, I don't think that many. Don't think these things, guys. You have to, guys and ladies, you have to actually really do these things. None of the things I mentioned cost a nickel. Nothing. Of course, you have to have time for a staff meeting, but you probably have those anyway. Have hypothetical case histories, speak for themselves, and so do actual patient histories. So I'm going to move on. But that's a good list. If you go all the way through that list and you don't see a significant improvement in your practice, call me, because it'll be the first time I've ever seen that happen. Crown counting, I've already mentioned, that is there. And so this is just a little more detail on it. Do your participants, when they view these things, can they look back on these slides later, Danny?
What we do is we as you know, we record, and that's why I redid the introduction. If you'd like, I can certainly send them the slide deck. We can convert this to a PDF and send it over to them. I was thinking that one slide at the very least.
The exercises. Yeah, so I'm going to just page, because I went through this. I just want to page through it. And these are just more detailed things I've already talked about.
Okay.
And now, this again, I think
time, just so you know, Bill, we're doing fine.
Okay, I'm thinking about 5-10 minutes. I should be here. Okay, you can go through all the different conditions now. Someone else. Who did I steal this from? I thought it was pretty good. When you're looking in the mouth, you tell the patient, when we look in your mouth, we're looking for 4 things, at least initially: decay, broken teeth, failing or old dental restorations, and infection. Now, if you are looking at the sort of stuff you and your crowd are looking at, there's these other items, right?
Mm-hmm. That's right. There's more. There's oral cancer for sure as well.
Yeah, and that's not even here. Vascular disease, diabetes, sleep apnea. You know, you're looking for other conditions. And you have diagnostic protocols for when do you take a lab test or not. I mean, this is something the hygienist should not interfere. When do you bring up the screening questionnaires, and how many positive or questions would indicate further actions taken? You can riff on these too, right, Danny? What else would you take here?
Yeah, our practices typically do a blood pressure on 100% of the patients. It's really,
and less than 5% of practices do that.
Right, and it's such an easy, simple way to get people thinking about the dentist in a different way. You know, you see us more often than you see your physician, and high blood pressure is such hypertension is such a easy thing to measure and such an important thing to know that even if you're pre-hypertensive, we have an opportunity to let you know that. And yeah, we mentioned oral cancer screening. We've got a number of different kinds of protocols that people employ for that. And Diagnodent is good. We've also got the Canary system, which even goes that even further, which does a wonderful job based on carious lesion detection way deep within the structure. And
I got to jump in on that. I do polls on these things, and in our area, around 45–50% of practices have laser caries detection, which means half don't. And so when I work with a practice that has that, I say you have to tell the patients this, because there's a better than even chance that in the other practice they didn't do it. We have this protocol that finds caries earlier. It's advanced technology, and here's what we're listening for as you go through. It's really important you do that, or you get that thing where you'll see a Google review that I went to this place and I've been to the dentist all my life, and all of a sudden I got 18 fillings. It's bull, And then, or you say go get a second opinion, or they do, and the next guy doesn't have a Diagnodent, and they're going, well, yeah, well, I don't see anything. And so
he doesn't.
that's a classic. If you're doing things that are different, you better explain why.
Especially, and then translate that attribute to the benefits for the patient, which is we're practicing preventive dentistry because to some extent, and I'm careful when I say this based on the audience, but we believe the best dentistry is no dentistry, at least. Yeah. If we can get it early and through remineralization protocols, we can help nip that in the proverbial bud, then why shouldn't we do it? But we can't.
Well, as your previous speaker was saying, almost every time you're doing a crown with a filling and a filling before that, and before that, so if you stop something on a young adult now, long after you're dead and buried, someone's going to be walking the planet that's better off because of your intercession. So that's
something good to keep in mind.
Get you credit in heaven or wherever you're going.
That's right. That's a legacy. Yeah, and if you believe in that, then you're putting some deposits in the karma bank.
Right. Don't have to come back as a bug. However you want to say it.
Yeah, exactly.
But anyway, so going through all these things, I talk primarily about treatment protocols, but then you have to work backwards to, okay, let's make sure our probing is consistent. And you go through the diagnostic protocols because they're obviously interrelated. They both have to be, if you say, here's when we're going to do perio, when we see, more than 4 pockets of 4 millimeters and bleeding and plaque and all that. But if they're not doing the diagnostic protocols the same, you're going to get different outcomes and recommendations anyway. So everything kind of comes from the outcomes you want. And so let's go to the next. This you can do a million versions of these. I like this clinical calibration ratio sheet. What you do is you're looking at ratios here. This might be hard for your readers to read, but I'll just read some. You look at the ratio of adult fluorides and varnishes to adult prophies. And you might use the same code. You might be using that 06 code and have to keep track of that else. It used to be adult and child prophies. It's easier to parse it out. Quadriplaning. If you see a hygienist that does 3 4341s per 100 adult prophies, but she's working right next to someone that's doing 12, you've got 2 hygienists that are diagnosing and delivering different. And this is really critical because if their presentation is the same, their ratios will be the same. Now here I don't feel guilty because this is not quotas. There's a big difference between quotas and criteria. Quotas are like saying you got to do 3 fluorides a day or 10 crowns a month or something. That's a quota. It's anathema to healthcare. I hate that. Criteria different. When we see patients that have a broken cuffs and an old filling there, we're going to recommend a crown. That's a criteria. When we see patients, so you say to the hygienist, if your criteria are the same, over time, your ratios will be the same. And that's the case. That it's just really consistent. If you go to, gosh, you're doing fluorides in about 5% of your patients. Betty Lou's doing fluorides in 60%. I think Betty Lou and you have different belief systems. Do you? Yeah, I think fluorides are a communist plot. Oh, Betty Lou thinks the best thing since sliced bread. Let's have the doctor talk. Let's get some kind of consensus. Okay, so I think this kind of, now I did one here where you have the practice, where you're looking at the overall practice, then you look at each hygienist, so the hygienist can see how they kind of compare to your own baseline. Again, very dangerous to make this a quota deal. It isn't. All you're doing is saying this is a window into our consistency. A function of quality is consistency. And if you're not checking the consistency between hygienists, you don't have the quality you want to have, especially in a large clinic. And this is the crux of everything we talked about too. More patient care isn't done because of the provider's fear of rejection than actual patient rejection. So in that, when you look back to it, that means your own ego. You know, you want your neighbor to love you, and you can do that to the extent that you don't want to get a rejection, but you basically underserve them. So a lot of treatment isn't presented because the doctor doesn't want rejection. But if you're advising people, recommending, showing them, giving them choices, adults like choices, if you take that approach and they say, no, I'd rather take my kids to Disneyland, I don't really want to do that now, that's their choice. You're comfortable, at least you told them your best advice, they're okay, the relationship's okay. So if you remove pressure, there's no rejection, and the relationship's preserved, but the case acceptance and confluence increases. And I'm going to go through these very simple techniques, and then we'll be pretty much through. The small talk phrase, everyone knows these, but most don't really pay attention to them. So after the small talk phrase, the hygienist should say to the patient something effective, Dr. Bobrow asked me to take a look in your mouth and show you what we're seeing as we go along because we want you to be involved in decisions about your own health. Or simply, the doctor asked me to show you what I'm seeing and tell you what we're thinking. And you might at this point say, I'm looking for decay, broken teeth, old dentistry, infection, whatever else you're looking for. And then you just take the patient through the mouth. Now, I've seen practice after practice. About 70% of practices now have intraoral cameras. At least half of those are used less than 5 times a week. Here's why. The doctor comes back from the convention, I got an intraoral camera. The hygienist sees the technology. So you are introducing the technology, but you don't have the culture. So you're giving the hygienist the Tommy gun, but you give them no idea of what they're shooting at. You've never talked about why they're using the intraoral camera except to sell dentistry. Now, if you go with them and say, look, we clarified the criteria. We need, if you really believe we'll get better outcomes for our patients so they make better choices, we want them to see what's going on and get our best advice. If you really believe it. Now you're going with a hygienist grain versus, I know you're really busy, but let up the camera, dang it. And it just doesn't work as well. So the preliminary look basically sets up the hygienist thing by saying, I am part of the diagnostic team. You are too, patient. Then the 15-second briefing. Now, here's a way your doctor can spend money. Tell him to tell a hygienist that they get to fine him $1 every time she enters a room and ask the patient directly, are you having any problems? That's a one question a doctor should never ask a patient if there's a hygienist or assistant already in attendance. Do you know why?
You're asking me?
Yeah.
It sort of diminishes the role and the power of the hygienist.
Yeah, I mean, if they've been there, the hygienist or assistant probably already found out if they have problems, and it short-circuits the whole briefing process. Plus, it wastes time. Almost any place I go to, you say that, and they go, oh, yeah, because they do it. Well, the patients withhold some time. They'll withhold less if the hygienist says, the doctor asked me to find out what's going on here and show you and find out about your problems. So when the doctor enters a room, the doctor has to acknowledge the patient as a human. How are you doing? How's the family, etc. But before they get clinical or touch the patient, they go to the hygienist and say, bring me up to date. What was your finding?
The previous slide where you talked about the preliminary briefing, I think that's a highly powerful technique, the preliminary look, because in so many offices, the hygienist will just dive in and start doing the work and may a little bit while he's going through the process talk to the patient, or just as often use terminology that the patient doesn't understand, and that was a topic.
They're glancing off teeth. It's all kind of like, oh, there's a thing there, you know.
And what we're doing here, it's a purpose statement. In classic sales, if you're going to have a presentation to someone, you make a purpose statement at the beginning, which purpose of which is to be sure that your prospective client, patient, whatever, is on the same page and also feels empowered, understands the why. And now they're engaged. They're going through the process, which means that they weren't just an impartial bystander to the process, so that when you come in and it's time for them to make a decision, it's almost like they've been asked to wake up. They weren't even awake during the process.
Yeah, and it gets rid of that patient as a victim mentality. You know, everyone knows about that, where they come in a chip on their shoulders if you created the dental problems. You're trying to help them. But again, I back off of using the phrase sales, although that is the thing on this, you know, in terms of the premise when you're talking sales.
I know you do, Bill.
But it's also the premise for giving anyone advice on anything.
For me, sales people have heard me say it before. It's communication with a purpose. It's empowering people to make informed decisions.
Okay, so we get to the 15-second briefing, and then the doctor at a certain point says, what are your findings? And you want the hygienist to take you through a pattern. Just, I always imagine like a captain on a ship. You come up on the deck, and you say, report. And the people on deck say, yes, we're headed, you know, south by southwest, 30 knots, right wind, you know, 50 miles off of Borneo. I don't know. And so the idea is the captain gets up there and gets an exact idea of where we're at. The hygienist is doing the same thing, guiding the person right in, going through the medical history concerns. It's really efficient. Another analogy is, it's like when the doctor walks in the room, they're getting the ball tossed right to their chest. They don't have to look around, where's the ball? Or another analogy I use is like when they come to inside the room and say hello to the patient, the hygienist has already teed up the ball. All they have to do is hide from the club, and they just hit it. In other words, they don't have to look for the tee, the ball, the club. It's all set up. Now, what are the two things that hygienists hate the most in the world? I'll tell you what they are. One, waiting for the doctor to do the exam and get in the room. Two, waiting for the doctor to get out of the room, right? And so if you do this preliminary look, it helps the doctor, but it also helps the hygienist keep on schedule because it's very effective. It's concise, and it brings the doctor in versus them wandering around. And the typical practice has 150 times a month of practices. And you want to give your hygienist feedback. At the end of the week, say, on a scale of 1 to 10, I want you, hygienist, to grade how well you think I did in backing up your recommendations for perio, home care, recall, etc. And I want you to grade me, but I also want you to grade yourself on how well you thought you set up my treatment, the co-diagnosis, and I'll do the same. Now, if the hygienist thinks she's a 5 on co-diagnosis and you think she's a 10, she should know that and feel better about herself. But if you think she's a 5 and she thinks she's a 10, she's got to hear why. So I'm giving you a 5. Why is that? What would it take to get you to an 8? Well, you do it well, but you don't do it consistently enough. That's the problem. Well, I get really busy. Okay, let's figure out how we can solve this thing so we get better outcomes for our patients.
The key is dialogue.
These two very simple techniques are things that you can adapt to your own personalities and practice, and you can spend the rest of your career perfecting, just like a golf swing. Because if it's done right between a doctor and a hygienist, it is so smooth, so nice, so humane, and then you're not sending patients to the front desk like a wounded bear for them to skin because they went up there with no idea of what things cost, or you send a confused, frustrated person to the front desk and say to the front desk person, well, we wounded this bear, you skin it. I mean, that's what happens. So if you do this, the patient at least knows where you're coming from. The vibes are good. The feelings are right. It works. And this is more about the 15-second briefing. Sometimes the patient will hold, so the doctor should ask, is there anything else you'd like to add to that after getting the briefing from the hygienist? If the hygienist misses something, the doctor should check her off. Like, what about the perio condition? Oh, no, that's fine. this goes on to say, let your staff know when they do a good briefing and when they don't. So if they do a good briefing, right in front of the patient, say, good eye, Susie, that right on, it's time, I think. Of course, it's your mouth, Mrs. Smith. You just tell us what you want to do and when you want to do it, and we'll do it. But Susie has a good point. And then if they don't do a good job, then away from the patient, say, you know what, I got a bunch of really lame briefings. When I come in the room and you say there's no problems, and then I look in the mouth, and you know from our calibration, there's like 6 problems there. You put me in the ditch, and I was in the hole trying to dig out. You can't say that. There was tons of problems. Oh, yeah, that's right. Okay. Otherwise, there's a danger the hygienist can be into perio and puppies, and you don't get anywhere else. So I want to end with this part. The care drives the numbers versus the numbers driving the care. So when I talked about those statistics, what you want to do is see those statistics moving because of the actually doing of the exercises we discussed. And you watch the needle start to move because you changed your behavior, because in previous staff meetings, you did not spend your time and behavior doing this. So in your staff meetings, if you behave differently, if in your interaction with your staff you behave differently, what happens is you'll get different outcomes. And if you don't behave differently, and it doesn't take much to get great outcomes, but if you don't behave differently by going through these exercises, nothing's going to happen. And if it does happen, though, it will show in the numbers.
Yeah.
But
it's like
if you say our goal is to do umpteen crowns a month or $20 million worth of perio treatment this year, that is not the way I would put it. I'd say if we, based on what we've done on our calibration exercises, if we consistently are implementing our protocols, we should see a significant increase in perio acceptance and delivery with all of us sleeping well at night. And we'll show them the numbers if we're consistently doing it.
Do the right thing, agree on what the right thing is, and the results will follow.
Yeah, and you'll see them in the numbers, and then it becomes, wow, what are we going to discuss our next clinical policy summit? It becomes self-reinforcing. So when you go to continuing ed, you come back and say, let's calibrate on this and make sure that what we're doing matches what we're knowing.
I like that point, Bill. That's really good, because I think what that helps to do is prevent this sort of enthusiasm wave phenomenon that happens, is that the doctor or the team come back and they're all jazzed about something they just heard or learned, and then they go back to their old way of doing things because they don't really have a plan to implement and instill or infuse that protocol into their philosophy.
Right, just let's do these things and it doesn't happen. So if you're moving, the numbers will move. And that's basically it. So that is the gist of what I have to say here, Mr. Bobrow.
And quite a gist it was, Mr. Rossi. And I want to just thank you briefly, but in the time remaining, which we don't have a lot, I've got a few questions I want to get to. And you did make a very generous offer that anyone who wanted to speak with you about any particular challenges they're having, or maybe some more information on how to implement the policy summit, that you would offer them 20 minutes without any sort of obligation. Is that right?
Yeah. I'm kind of on a mission on this, plus the PPO thing, which we can't get into now. But if they call and mention that they're in the webinar, or just call and want to talk, that's not a problem. I'm happy to talk, and you will not get any sales pressure from me, believe me. So nope. If you want, I'm on a mission on this. Huh?
Can you advance the slide?
Oh, yeah, the contact. Yeah, there's my number. And if you Google my name, I still come up pretty high on that. I keep on waiting. It's like mirror. I'm still the #1 Bill Rossi in the world. I don't know why, but I'm afraid to look anymore because someday I'm going to slip. But if you Google my name, that will get you there.
Let me jump into a couple questions real quick, because we are coming up against the time flies. I was enjoying it very much. One question is, are you talking about new patients here or existing patients? If these are new patients, you suggest the hygienist sees the patient before ever meeting the doctor, and the first meeting happens in the dental chair?
What do you mean, are these new patients?
Well, that's a good question. I'm not sure what the context of this, but I guess everything that you're recommending, they're asking if it applies to new patients or existing. I would imagine.
Yeah, okay, all right. Oh, that was one of your listeners' questions. Okay. Here's the thing. In doing this 30 years, I still don't know the best way to intake new patients. Doctors like the Panky Dawson thing where you have a lot of time with them. however you input, so I don't have a strong opinion because I have people over the board on it. But if you're having them come through the hygiene, they especially have to be calibrated, don't they? So whatever your new patient intake scenario, if I understood that question right, this stuff applies. But I don't have a strong belief on the right way to bring in new patients. I think offices should be flexible. And actually, one of the protocols I work on with clients is, when is it acceptable for them to go through hygiene? When should they see the doctor for, so there's some flexibility, because sometimes there's a problem getting more new patients. If every new patient has to have 2 hours in hygiene and the doctor's schedule, you can't get them in for a month. So,
yeah. In my experience, the only thing I would do is I wouldn't in any way discriminate against new patients. I have some clients who, because their first visit is complimentary, try to abbreviate the presentation.
No. That one, that's a different question. If they're coming in because of some kind of offer or something, yeah, they get the same royal treatment everyone else does. That's the whole point, is to have them get turned on to your office.
Exactly. See, they have a choice. There was a question if we could get a sample of the clinical calibration ratio sheet. Yeah, I mean, I will go ahead and send the slide deck, and presumably people will be able to read it if they just,
Yeah, they would. Or again, they can call me in my office. This is just one version, and I guess I don't want to be bothered with sending out 20 different versions, but I think it's pretty apparent what the idea is here. And if the slide deck doesn't show clearly, they're welcome to call, but it's pretty clear, I think, for the average person to know how they can adapt that for their office.
Okay. And here's a question. How can we tell if we are making progress with clinical calibration? I think
your production per exam will go up, or your crown and bridge per exam, or your implants per exam, or your fluorides per adult prophies, or your whatever for whatever. But the definitive procedure, if you're delivering more for the people you see, will be your production per exam will go up.
And this one, I think, was probably asked before you addressed it, but how should I track my treatment acceptance percentage?
Yeah, well, we talked about that earlier. You can track it. I think it begs the question, what are you presenting? And I don't like tracking that percentage, because to me, it can sound like a closing ratio, but your guess is as good as mine as how to do that, if you did want to do it. Like if our treatment coordinator has 10 consults, what are they presenting, what are they accepting? I mean, it's not totally invalid, but I like to see what happens per patient based on the math and the numbers there, because that just doesn't lie.
Yeah, I mean, I think seeing a positive trend is always a good thing, too. We have time for one last question. How often does crown counting yield different results between the hygienist and the doctor?
Interesting. Not often, but sometimes it does. And, there are some times where the hygienist isn't compatible for the office. The doctor has to stay. I mean, he can't. But there's sometimes, like I mentioned, I've been in offices where there's hygienists, for example, that really don't believe in fluorides. I mean, or just do not think they're a good thing. And, of course, what the office does, as a group or the doctor does, it just may not be a match. Usually, though, if there's a difference and they start talking it through, they get, oh, okay, you're talking about now versus later or something. So that difference is not anything anyone should feel bad about. It's something you want to talk through. And usually, if you can talk through it rationally, you'll reach a consensus.
You'll close the gap, yeah.
Yeah, you'll close the gap. And, again, your staff, if you can get your staff to have the same expectations you have and vice versa, that's the first step in getting the patients to have higher expectations.
Excellent. All right, Bill, well, the time has come to sign off, and I just want to, again, I thank you for what I knew would be an excellent and powerful demonstration of the power to more effectively gain treatment acceptance. Attendees should please watch, and remember to watch their email for instructions on how to receive their 2 hours of CE credit. And also be sure to reserve time in your schedule for Wednesday, August 27th at 6 p.m. Central Time, when our next Practice Perfection presenter will be Alexander Sleepak, MD, who will present through case study how he transformed a struggling dental practice into a periodontal powerhouse and how you can do it as well. In the meantime, this is Danny Bobrow thanking and acknowledging you all for your commitment to practice perfection. Goodbye, everybody, and thank you again, Bill.
Thank you, and by the way, out there, if you have success with these measures, please let me know.